everyone. Go ahead and feel free to take your seat. So it's great to see all of you on an Easter week. So thank you so much for your time this afternoon. So it's a pleasure to see all of you. My name is Bella O'Hare, and on behalf of Let's Talk Vero, which is Irina Wolfley and Jonathan Buckley, it's our pleasure to welcome you here tonight. We have a special guest speaker, Dr. Richard Rothman, who is the Vice President and Chief Medical Officer of our local hospital. And we also asked John Coutinho, our mayor, to give a couple of comments before Dr. Rothman starts. Forgive me, I always get nervous when I get going. I'll try to do better next time. Always sweat through my jackets when I do this. All right, so let's talk Vero. So our goal is to educate, enlighten, and engage our community. As you may know, Irina and I work full time, but this is something we just kind of fell into in terms of being passionate about having a community conversation about what's happening here locally in Vero Beach. And so needless to say, we are very pleased to be here and to continue to offer these conversations to you and our community. So now here's the part of audience participation. Would you be kind enough to raise your hand if you've been here before? Oh my gosh. Okay, I won't even ask who hasn't been. That's really awesome. That's really, hi. This is really terrific. Thank you so much. May I ask how many of you are residents of Vero Beach city limits? Okay, wow. Last and third question. How many of you have used the services of our local hospital within the last 24 months? Okay. All right, meeting adjourned. No, I'm just kidding. So I wanted to also share with you so you know where you are. So since you've been here before, you've heard me talk about the theater. And so you're in the Waxlax stage. So you may have heard me say before that this is Florida's largest nonprofit producing theater. And our general manager for the theater is Lori. She's back there. And thanks to her and her kind staff that are kind enough to volunteer their time for us tonight. So it's a real treat. So the only money maker tonight is the bar. So don't stop drinking. The bar is open all night because the Beautiful, which is the last show for the season, starts tonight at 7:30. So hence the bar is quote unquote, as they say, open. So the theater obviously is a huge part of our community, just as the hospital is. The hospital and the school board are the two largest employers in Indian River County. And the theater is close, but not obviously as big. So the theater employs about 100 full-time people. Most of them live here in the county. The average, the total income the theater pays to these 100 people is roughly $2.5 million. And since they all mostly live here locally, the money stays here in the community. Also during the season, the theater hires roughly 200 artists. This is not a traveling show theater. They actually produce everything here themselves. And they go to New York City in the fall, and they audition all these talented young people in New York City that one of these days want to hit it big. And so they get some terrific talent here. So they hire about 200 artists during the season, and believe it or not, they have over 500 volunteers. And so all the nice folks that seat you and hand you programs, etc., they are all volunteers. And so the theater likes to think that this right now is the community living room. And so hence they're very happy to help us engage all of you with quote unquote current events. So I wanted to give some just high-level stats about the hospital. I've heard Dr. Rothman speak before. I'm sure you will enjoy the conversation and what he has to share with you. So very high level, last year, the hospital earned about $471 million, and it spent about $520 million. So you don't have to get out your calculator. It's about $47 million, $49 million is the difference in terms of operating loss. And I know they're working very hard to close the gap and then go positive. Since so many of you raised your hands, I assume you may have been here when we had Habitat for Humanity here and we talked about the ALICE population. ALICE is asset limited, income challenged, and employed. We have about 44% of all of our households here in Indian River County are in that category. And so that will help you visualize or understand why almost half of the operating loss is allocated to those of us here in the community that either do not have insurance or underinsured or are impoverished. So the hospital does take care of all the charity and charity members of our community. So Dr. Rothman, we're very appreciative of your service. I think it's a yeoman's job to do what you do, and a lot of us have a lot of respect for what you offer to our community, so I assume you have to be passionate about what you do. And I wanted to share with you real quick a story. I know one of your colleagues that really was looking to work less, but he decided to take an extra work in your hospital. And I knew he really wanted to, quote unquote, work less. So I asked him, why did you take on some extra responsibility? And his answer was, I'd much rather be part of the solution than the problem. And I thought that was a wonderful answer. And so I assume you and all of your colleagues and your staff must have the same passion as my friend does. So, I usually forget to say something. We'll figure it out later on. But Dr. Rothman obviously has a slideshow. I'll walk around later on with the microphone so you can ask any questions that you may have. And I would like to introduce to you Mr. Coutinho, there you are, who is our mayor. And we asked him just to give us a quick update on Three Corners. And then I will more formally introduce Dr. Rothman. Okay, great. Gotta be quick.
I'm gonna be quick.
I'll get the hook up.
Please do. Okay, this is gonna be really quick because I know Dr. Rothman has plenty to share with everyone, and I'd like to thank everyone, like Garavel and Arena and Let's Talk Zero for providing this forum as they've done. I guess we're in our second year now, right, of doing this, and it's been great as an outreach and getting information out to our city. So this Tuesday, 4/22, is the big day. So the big day. City Council will be very busy that day. We will have a regular scheduled City Council meeting, which begins at 9:30. Hopefully the agenda will get done close to noon or earlier. We'll then break in the afternoon. There's a session where we will interview the two developers that are up for the Three Corners project. We'll take a few hours to do that. That is closed to the public. Okay, that, by Florida statute, that's a closed process. Then at 5 o'clock, there will be a special call meeting. And the special call meeting is when the City Council will get to discuss the interview process. Because as you know, by Florida sunshine laws, we don't sit here and Councilman Carroll's here and Councilman Voss is out there. We don't sit there, as you notice, they can't get any further apart. There's a reason behind that, the Florida sunshine laws. So we can't have a discussion about what we thought about the proposals until we actually do it from the dais. So we will discuss our feelings about how the interview process went, and the developers will then have open it up for public comment, and then after that we'll have a vote. So I encourage everyone who is interested to come out to the 5 o'clock. It'll begin at 5 o'clock, that part of the process. If you have an opinion, please express it. and we will look forward to everyone being there. And if there are any questions on anything else to do with the city, I'll see you afterwards, okay? And that's it.
Sounds great.
Thank you.
You can drink and chat about Three Corners. So Dr. Richard Rothman, we put on your tables his bio. What we didn't put down is that he has 2 little girls that he is obviously head over heels in love with, and they go to St. Edward's, and I just asked him how it was going, and he said they love it. So they're happy campers. That's very important to be a good dad, right? So Dr. Rothman graduated from St. George's University School of Medicine in 2009. He completed a postdoctoral research fellowship in Boston, Massachusetts, at the Massachusetts General Hospital, and completed both his internships and residency at the Lehigh Clinic, also in Massachusetts. He received his diploma in internal medicine from the American Board of Internal Medicine. He is an active member of the American College of Physicians and Society of Hospital Medicine. And his little girls are Madison, she is 7, and Emily is 5. So thank you so much again for joining us.
Thank you guys so much. I'm gonna use the microphone here. Can everybody hear me okay?
Yes.
I have a tendency to lose the microphone. I'm gonna move around a little bit. So thank you guys so much for coming out tonight. We're gonna get started, but before we do, the way we deliver care today looks a lot different than the way we delivered care yesterday. The way we deliver care tomorrow is gonna look much different than the way we deliver care today.
Yeah, we're missing a human upstairs. You wanna use this one, and you can take it out, we've got a long board.
That's right.
Yeah. Needless to say, they're trying to do the show.
It's okay. We're going to take you on a journey of the Cleveland Clinic Indian River Hospital with the intent that by the time everyone walks out of here, we'll have a better understanding of our hospital and the healthcare system in Indian River County. What's so promising is if I were to ask any of you where one of the top 10% of hospitals is in Florida, you probably wouldn't guess Vero Beach. If I asked you where one of the top stroke programs, open heart surgery programs, you probably wouldn't guess Vero Beach. By the end of this discussion, I'm hopeful that everyone will have more insight into the care delivery here at the Cleveland Clinic. On the next slide, here, talk a little bit about the history. So like any good thing in medicine, it's always led by nurses. So at the age of 29, Garnet Lunsford Graydon purchased a piece of property for $22,000. This was a hotel, and she turned this hotel into a hospital with one purpose in 1932, to create a place to take care of people. Well, then in 1941, Eastern Airlines, I had to look that up, by the way. Some of you in the room may know what Eastern Airlines is. I did not. So Eastern Airlines, yeah. So, but look, this is important. Come on, not everybody knows what Eastern Airlines is.
You have to be old enough.
Yeah. So in 1941, Eastern Airlines plane crashed out west in Vero Beach. And when you go out west in Vero Beach, even then there was marches, there still are today. What was so interesting is a gentleman named Dr. Kreil was on the plane that crashed. Dr. Kreil was the founder of the Cleveland Clinic. And so Dr. Kreil was raised over to this hospital, started by, of course, a nurse. And he was treated by somebody named Dr. Collar, and he looked at Dr. Collar and he said, "I know you." And Dr. Collar said, "I know you, you trained me." Dr. Collar was from the Cleveland Clinic. Dr. Collar treated Dr. Kreil. Dr. Kreil did well. And then fast forward to 1948, Garnett's hospital continued to grow. And in 1948, she temporarily relocated the hospital, now 35 beds. And after the war, she decided that she really wanted to invest herself in taking care of people. And she continued to grow what was then the Indian River Memorial Hospital. Fast forward to the next slide. You can see what the hospital looks like today. This is actually the largest hospital in the Cleveland Clinic Florida system, with more than 330 beds, an additional 40-bed inpatient psychiatry unit, the only inpatient psychiatry unit that can take care of little toddlers all the way through to adults, within about 100 miles. Is in the top 10% of hospitals in the state of Florida, as ranked by US News and World Reports. The Cleveland Clinic system, as many of you know, was recently ranked number 2 in the world. So, on the next slide, you can see the breadth of services now being offered and the geography across Indian River County. Sorry if I'm blocking you, just yell at me. Don't yell at me. Across the county, there are locations: our main campus, the Rothman Family Health and Wellness Center, the Scully Walsh Cancer Center, perhaps the most advanced cancer center between here and Orlando, and from here probably down to one of the university hospitals in Miami. A Rubenstein Family Hospital Care at Home Suites, which recently opened. For those of you that don't know or recognize the name John Rubenstein, thanks to John and Karen. John, he developed this thing, designed this item called the iPod. Many of you may have used it. Subsequently the iPad, and designed the Macintosh with Steve Jobs. And John actually lives here on the Barrier Islands. Wanted to do something special for both the hospital and the community, and invested in the command center that houses our caregivers delivering acute hospital care at home, from here all the way down to Weston, across 180 miles. Headquarters is here in Vero Beach. Of course, our Point West location, we talked about the Behavioral Health Center, Vero Beach Radiology, and our urgent care out in Sebastian. That's what we look like today. It doesn't really tell who we are. So in the next slide, I love this video, and I think it says something about the 2,500 caregivers that care for patients at the Cleveland Clinic Indian River Hospital. And as you watch this video, I want everybody to think about the largest employer in this county, 2,500 people, most of whom have families. About 10,000, 12,000 residents in the county attached to the Indian River Hospital. By the way, there's only 180,000 people in the county, of which 25,000 are kids. My guess is about 25-30% are not here year round. It's about 10% of the county. And this is how they think. every day, 2,500 people wake up and drive to the hospital to do what you just saw. Healthcare is a really challenging business. In no other industry is there zero margin for error. Everything has to be done right. Access is paramount. Time matters. There's insatiable demand, and there's not enough supply. So the Cleveland Clinic Indian River Hospital did over 500,000 outpatient visits. By the way, I said there's only 180,000 people in the county. Our emergency department saw more than 50,000 people. For those of you that are interested, half of the week, this is the busiest emergency department in the entire Cleveland Clinic, including our main campus, the #2 hospital in the world. The emergency department was only built for 30,000 people. We're doing nearly double that. We admit over 20,000 patients a year, perform more than 11,000 surgeries and procedures, and deliver over 800 babies. What matters most in healthcare, what we are laser focused on and obsessive over, is the outcomes of our patients, the experience of our patients. It's interesting when I talk about healthcare today, not many people ask me about outcomes. It's access, it's phones, I had to wait. I don't get asked about outcomes. This is the most important metric that you guys are gonna see tonight. If you come into the Cleveland Clinic Indian River Hospital with sepsis, meaning you have an infection from a pneumonia, urinary tract infection, influenza, COVID, and you're septic, you're twice as likely to live at this hospital as like hospitals across the country. I get it, the emergency department wait times are long. You're twice as likely to live. By the way, for any condition admitted to the Cleveland Clinic Indian River Hospital, you're more likely to live than most hospitals across the United States. And by the way, if you get admitted to our hospital, the likelihood that you're gonna get readmitted is about 12.5% within 30 days. National average is between 15 to 18%. So top 10% hospitals in Florida, more likely to live, caring for more than 500,000 encounters a year in a county of 180,000 people. On the next slide, you can see we recognize that we have challenges. All of the challenges that I spoke to you about, an insatiable demand for services, not enough supplies, those are explanations, those aren't excuses. We are in the business of caring for people, and we are gonna continue to take care of people. You can see back in January of 2024, our overall rating of the emergency department was quite poor. Something happened in June, July. It wasn't me starting. But all of a sudden, our rating of our emergency department is approaching the top decile. We got new nursing leadership. It's always the nurses. It is. New nursing leadership came in. And the new nursing leadership was obsessive over the experience of the patients. They recognized they couldn't suddenly build a new emergency department in a month. But what they could do is ensure that when you came in, the only person they cared about was you. And so you can see the overall ratings of the emergency department are now approaching top decile. They actually created an additional 35 or 40 MASH units. Some of you may have seen it if you came to our emergency department. Similar to Eastern Airlines, I had to look up what MASH was. But they created these, it looks just like a MASH unit. There's a chair, there's a screen, chair, screen, and there's 40 of them. ED was built for 32,000 people. We do more than 50,000 visits a year. The reason for that is when patients are sick, they're not going to our partners to the north, our colleagues to the north, or our colleagues to the south. They're coming to the clinic. So as we think about that, I'm gonna pause and talk about the state of healthcare, and then we're gonna come back around to the volumes and what we're doing about it. So this is across the country. This is not just in Indian River. We are certainly not immune to it. Across the country, there's an increase in uncompensated care, meaning patients that are coming into our hospitals or seeking service that can't afford to pay for it. Inflation is outpacing government reimbursement, and we'll talk about that. Essential services are challenged by underpayment from public payers and losses even after factoring in commercial payments, meaning for many of the patients we see, we don't make $1 on. And then labor shortages, high attrition rates, and recruitment challenges. Anybody want a job? But the point is, this is our business, and we're not the only business where inflation outpaced reimbursements. The difference is, we can't up our prices. We have to redefine how care is delivered. I can't call United Healthcare and say, hey guys, tomorrow I want more money. Say, talk to us in 5 years when the contract is up. We have to redefine care delivery. Number 2 is important, inflation outpacing government reimbursements. 70% of our reimbursement at Cleveland Clinic Indian River Hospital comes from Medicare. 70%. So very often I get calls and say, well, why don't you go speak with the commercial payers and get a little more money? Yeah, it's about 10-12% of our book of business. What about the rest? Well, that's Medicaid, self-pay. On the next slide, you can see the uninsured rates in the US and Florida. I'll talk you guys through this for those of you that can't see it. To your left, what you're looking at is uninsured rates among the non-elderly patient population. Really important slide, guys, really important. The darker, the less insured. So there's Texas, Georgia, Alabama, Mississippi, and Florida have the highest uninsured rates in the country. Go to the other side, and you can see the impact of Medicaid expansion. So, what this slide is showing is certain states adopted programs that would allow patients that couldn't afford insurance to have access to it through the Medicaid program. You can see here, all the blue adopted Medicaid expansion. In the green, Texas, Mississippi, Alabama, Georgia, Florida, actually restricted it. Impact on this county, an additional 15,000 people no longer have the ability to pay for health care. I'm not here to debate whether it's right or wrong. The reality of it is, these patients don't stop coming into the emergency department. Your heart attack, by the way, doesn't go away because you don't have insurance. And we can't turn you away because you don't have insurance. We just led this with, we are in the business of taking care of people. We need to figure out how to do it. On the next slide, you can see the pressures that, not unique to Indian River, but this is really important to us because 70% of our reimbursement comes from Medicare. So on your left, you can see inflation is this blue bar, 12.4% from 2020 to 2023. The light blue is what our increases in reimbursements were over that same time period. So inflation, 12.5%, our reimbursements increased by 5%. You could do the calculus on this. That means for 70% of our patients, we start upside down 7% immediately, the moment the patient walks in the door. On the other side, on the other screen, you can see growth in total hospital employee compensation. So again, blue line, represents the average employee in the United States saw wage inflation of about 30% over 10 years. In healthcare, that number is 45%. Largely because of the pandemic, and what we just described. There's a supply-demand mismatch. There's not enough nurses, there's not enough doctors, and so if we want to get the clinicians here, we need to pay them more. And so all of these economic pressures hit our hospital. Some of you may have read in the papers about post-pandemic, Cleveland Clinic Indian River Hospital took a loss of about $68 million. That's an operating loss straight to the bottom line, $68 million. Sounds like a really big number. Oh, it's a really big number. Yeah, don't tell it to my boss. So big number though, guys. So $68 million straight to the bottom line. There are not many healthcare systems that could have absorbed a $68 million loss. Mass General took a loss of $1 billion coming out of the pandemic. $1 billion. But coming out of the pandemic, something else happened, and this is really important. Remember, in 2019, when the hospital was first acquired by the Cleveland Clinic, that first year, you can go on side, that first year was all about building relationships. The electronic medical records didn't change, nothing changed in the first year. So 2020, the second half of 2020 was supposed to be when the integration started. We didn't factor in how to integrate a hospital during a pandemic, and so we had to wait until about coming out of 2022, 2023. So now, I just want everyone to just think about this for a second. So 2023, if I don't fall here, it'll be a miracle. The 2023, we come out of the pandemic with a $68 million loss, and by the way, now here we go. We gotta start integrating the hospital. It doesn't mean that we're distracted from our mission. And so I'm going to talk a little bit about what the Cleveland Clinic Indian River has done to serve their community. I'll talk about charity care, expansion of clinical service offerings, and then I'll get through this pretty quickly, and then we can have a robust discussion, and I'm happy to answer any questions almost any question that this group might have. They may not let me answer them all. But I want to start by saying, this is the largest employer in Indian River County. We talked about that. This actually happened this morning. This was 6:30 this morning. This is our surgical teams. So every quarter we do what's called a stand up for safety. Anyone who does procedures in our ORs or GI suites has to come. And we stand up and we talk about things that we could do differently to improve the safety of the care we deliver. So you can see here, 6:30 in the morning, all of our team members gathered to talk about events. You can see surgeons, radiation oncologists, nurses, scrub techs, circulators. This is what it takes to run a hospital. And all of these people have to be recruited from somewhere. This is also another snapshot of Patient Safety Awareness Month. This was last month. You can see the emphasis we put on patient safety. We were laser focused on the patient experience. Somebody asked me, what's the most important metric that matters in your hospital? Patient experience. No, what's the most important metric? Patient experience. That's the outcomes of our patients, the access of our patients. The teams have to be obsessive over it. This is what that looks like. Now, since 2019, a lot has happened. What many don't talk about is the hospital here is quite old. And how many of you are familiar with the hospital up in Rockledge? So in Rockledge, so Stewart Healthcare sold, auctioned 3 hospitals: Melbourne Regional, Sebastian River Medical Center, and Rockledge. And those hospitals were acquired by the Orlando Health System. One of those hospitals required Rockledge somewhere around $300 million in capital investment to bring the hospital back up to the standards of a system as good as Orlando Health. Does anyone know what happened to Rockledge Hospital?
They closed it.
They closed it. by the way, go back a slide, thanks. By the way, Garnett would not have been happy if we closed the hospital she opened just after the Great Depression and during World War II. If she could do it, we could probably figure out a way to do this. So we didn't close the hospital. We put in 120 million in capital and invested $200 million in operations just to support these losses coming out of the pandemic. What's also important to know is many of the investments that we make, no one in this room will ever see. So the CEO of the Cleveland Clinic flew down to let me know that I was getting $30 million to fix the power plant. And by the way, that 30 is only a third of what's going to be needed over the next 5 years. The power plant alone is a $90 million capital investment. You can't run a hospital on a power plant. On the next slide, you can see some of the trends. So this is something that some of you may have read about. These are the patients that we take care of that don't have the ability to pay. So 2019, I'll call it a couple things. 2019, we took care of 645 acute inpatient admissions. In 2024, that number increased by almost 15% to over 900. Our emergency department visits in 2019 were 3,900, increased slightly to 4,100. What's really important though, that I think everyone should pay attention to, is this number here. So general surgeries in 2019, the year of the acquisition, were 107. We had 170 surgeries in patients that couldn't pay. In 2024, that number is 333. I wouldn't ask anyone to guess how much the surgery costs. Some of these are open heart surgeries. In addition to that, endoscopies, by the way, are really important. If you're over 40, 50, probably have colonoscopy. You should have a colonoscopy. In colon cancer, it doesn't discern between whether or not you have insurance or don't have insurance. You still need a colonoscopy. In 2019, we did 108 endoscopies on patients who couldn't pay. That number doubled in 2024. Keep going on and on. Radiation therapy, we did 130, I'm sorry, I apologize, 80 radiation treatments, and those are recurrent treatments. 80 patients received radiation care at the cancer center. Last year, more than 400 did. That means on average, it's only 252 business days in a year. On average, 2 patients a day were in our radiation centers getting therapy. I don't know if anyone has had to tell somebody with breast cancer that they can't get radiation therapy because they can't pay for it. We weren't going to be the ones to do that. And so, on the next slide, you can see what it cost us. So, unfunded care in 2024 was $22 million, 21 point. That's up from last year, 18 million. Some of you may have read some articles about charity care. What we had said was, and what many of you were reading, by the way, we weren't asking for a bailout. What we were saying is that we anticipate charity costs to continue to rise over the next 5 to 10 years. We still anticipate charity costs to continue to rise over the next 5 to 10 years. We just told you that Medicaid is being restricted, there's more uninsured patients, there's more demand for care, people are getting older. The calculus is pretty straightforward. And so you can see here, indigent care provided to the residents of Indian River County increased by 22% in 2024 from 2023. That's a huge number. We expect this number to climb again next year. And you saw the services that are being offered. On the next slide, there's something called fair share spending. I'll explain this kind of in layman terms to the group. So we're a not-for-profit, okay? As a not-for-profit, that means the government gives us what I would consider to be a subsidy, a pretty big one, by the way, so we can invest in the communities that we serve. This actually was just released, I think, yesterday. This is called fair share spending. In other words, what you get back or save in taxes versus what you put in the community. If you have a surplus, means you put more money into the community than you probably got back in taxes. This is the top 10 hospitals in the state of Florida. There's over 300. Indian River Hospital had the 7th largest surplus in the entire state of Florida. Meaning, we invested $23 million more into this community. 23 million. Than we got back in taxes. On the flip side, if you don't invest in the community, it's what's called, what they call a deficit. The largest deficit is Orlando Regional Medical Center, Orlando Health. It's a $100 million deficit. Interestingly, those 10 hospitals there, Lakeland Regional, Mount Sinai, Cleveland Clinic, Indian River Hospital, Tampa General, account for 30% of all healthcare investments in the communities. And you're standing in one of them. On the next slide, what I want to emphasize is we continue to invest. We want to ensure, I'm going to tell you how. We want to ensure that we are not looking at this as excuses. These are explanations. Healthcare is important to everyone in the community, irrespective of your demographics or your ability to pay. So our hospital continues to execute on a plan to reimagine and create a sustainable healthcare system for the residents of Indian River County. That's actually a really true statement. So year over year, so I came in June, our operating margins have improved by 21%. We expect by the end of this year to get back to at least a break-even. In other words, $68 million loss in 2023, by 2026 back to break-even. That's what happens when 2,500 people come to work every day, dedicated to do one thing. And go to the hospital, ask them. They're dedicated to take care of patients. It doesn't mean that we do it perfectly every time. But they're doing it a lot better than we did over the last few years. Other things that we're doing, on the next slide, we talked a little bit about the power plant. I won't get into that again. That's a $90 million investment over the next, through 2028. And the first 30 million is being distributed this year. That's for a generator. On the next slide, you can see the things that we're doing. Emergency department renovations. We said our emergency department was small, and it looks like a MASH unit. This time next year, it'll look a lot less like a MASH unit. We're adding nearly 40 care bays. It's a $21 million renovation of our emergency department. Part of that is expanding our cancer suite, where we give infusions for cancer care. You can see here, this is what I don't know how many of you have been to what we call the patient pavilion. That patient pavilion is soon gonna look like this. We're gonna be expanding what we call a flex care area. So if you come in and you need to be evaluated, but you don't need to be admitted, you're not having a heart attack, maybe you need stitches, or you're coughing and you have a fever. This flex care area will be able to triage you quickly. We're also investing in something else on the bottom right of your screen. That's labor and delivery. So across the country, the most commonly shuttered services, labor and delivery, and mental health. Reflect on that. The most vulnerable patient populations, babies, moms, and those with mental health disorders. What I'll tell you is we've never made a penny on labor and delivery. As a matter of fact, we lose about $7.5 million a year. We're doing a $7 million renovation. Next slide. We have so many successes, and those are the headwinds. That's kind of what's happening in the community. Maybe a little more granular than everyone here wanted, maybe not. But on the next slide, we'll quickly go through this. This is what our operating rooms look. This is what an operating room looks like today. I don't know if any of you could pick up on it, but the surgeon is actually in white, sitting in what looks like an arcade. That's a robot. That's how we do prostate surgery today. It shouldn't surprise you that we have some of the best surgeons, both employed by the Cleveland Clinic and in the community, not employed by the Cleveland Clinic, operating at our hospital. We have, by far, the best technology on the Treasure Coast. Here you can see Dr. Zeal. That's a new machine for a piece of medical equipment that's used to simulate radiation therapy. So before you get radiation therapy, what we do is we have you go through the CT scanner, we map out where the cancer is, and then with sub-millimeter precision, we're able to treat the cancer. We use what's called TrueBeam technology. These are $4 or $5 million machines that are available nowhere else in Indian River County, so that we minimize side effects. In many cases, you no longer need your prostate taken out. We're able to cure it with radiation. The same is true for a number of diagnoses. Many patients who have certain cancers in areas that they'd rather not have cut off, i.e. skin cancer. I know almost everyone's been to a dermatologist. And eventually, if we live long enough, dermatologists only do one thing. They're really good, by the way. But they biopsy and they cut. The technology we have allows us to do radiation to areas that we may not want to have cut. And then on the next slide, we focus on heart care. We're the #1 heart center in the world. We have electrophysiologists that do all kinds of ablations for things like ventricular tachycardia, atrial fibrillation. Today, we're able to cure atrial fibrillation, put in a device called the Watchman, take you off your blood thinner. It shouldn't be surprising that this is one of the highest volume electrophysiology centers in the Cleveland Clinic. People drive from everywhere to come to Cleveland Clinic Indian River Hospital for Dr. Faulkner and Dr. Hannah Bishoy. On the next slide, we talked about labor and delivery. Some of you may know Dr. George Fife. He always smiles like that. He's probably delivered well over 10,000 babies. And he's a really good gynecologist. So we're investing in labor and delivery. We're investing in labor and delivery. On the next slide, we talked about the emergency department. And then on the next slide, keep going, one more, there we go. This is my favorite slide. So this is a picture of a nurse today caring for a patient that's acutely hospitalized. We talked about how we reimagine care. That's a nurse caring for acute patient. She's on a treadmill. She's actually on video with the patient at the Rubenstein Family Command Center, treating a patient through hospital at home. And if anybody ever wants a tour, we'd be happy to show you around. She doesn't look like she's about to quit her job. We have to reinvent how care is delivered. Our teams at the Cleveland Clinic are committed to doing that. I thank everybody for their time, and I'll open it up for questions. Thank you.
This is where I get my steps in. Let's see, what did she do with the mic?
It's right here.
Oh, great, thank
And the
you.
pink was first. And
Put
the
the
pink
battery
was
in.
first.
Okay, we got it. Have batteries, will travel.
Here we go. Ta-da.
Is there any chance that Cleveland Clinic would become a center of excellence for any sort of conditions and pair up with FAU or FIT or UCF?
Okay, great question. The short answer is yes. We're currently evaluating 4 clinical services to determine whether or not we will become a center of excellence in those services. We currently partner with FSU, where we have medical students from FSU rotating through the hospital. We also have VCOM students, about 30 at any given time, rotating through the hospital, and some of you may have heard about the medical school campus, that we will be a part of teaching the medical students here. So the short answer is yes. Across the Treasure Coast, all of our hospitals are engaged with those same medical schools. And as we think about it, it's a really good question.
Can you explain what a center of excellence is?
Sure.
first?
Sure. A center of excellence is a designation given to hospitals who deliver high quality services focused in certain areas, in layman's terms. Depending on the service, they have different contingencies. So as an example, we have a center of excellence in neurosurgery down in Traditions Hospital. We are evaluating becoming a center of excellence in spinal care at the Cleveland Clinic and Indian River Hospital. What's important about that is it really forces all of us to think about what are the things that we want to focus on and do really well. Nobody in this room would come to the hospital and be evaluated by us and we say, you know what, we can get you somewhere that does this really, really well. Or we can do it really, really well here. And both of those answers be able to say with a high degree of confidence. We can't be everything to everyone, and the centers of excellence are a way to refocus our teams. And there's one way that we're achieving the sustainability of, the one way that we're achieving sustainability here in Indian River County. Thank you for the question.
Hi, I'm Sheila from Able Child. Thank you so much for coming out and doing this presentation. I'm probably one of your biggest critics as far as asking for a bailout, and I think it took a lot of courage for you to do this community events. I have a question. I work on informed consent regarding mental health, and I don't see anywhere where Cleveland Clinic educates the doctors or the patients on MedWatch. Like, I would think that it would be really important to have MedWatch forums all over. We know that the pharmaceutical industry visits the hospital on a regular basis. You have these wonderful implants that are going in human beings, but we need human rights. And that's a real focus of my organization. So I'd like to know, why don't you have any posters throughout the hospital that says, MedWatch, this is how you report an adverse event of a drug or a medical device?
It's a really good question, and it makes me think about walking through my hospital today and seeing where that opportunity is, and I would love to do that with you. We do have, probably not visible enough, areas within the hospital for patients to see, I want to report something. But it could be clearer, and I think that's the point. It could be a lot clearer. I don't have a great answer for you today, but I'd love to walk through the hospital with you. And if you get with Kelly and Nancy, we can go take a walk and I can bring some of my quality team. Okay, all right.
Hi, people will tell you that I ask hard questions. I was on the finance committee of Indian Memorial for a while, 20-some years ago, so it's been a long time. But what I wanted to ask about, well, a lot of things I wanted to ask about, but you mentioned the Heart Center and how we have a great Heart Center here. And I've heard a number of cases, and one of them happened to a friend of mine, where he needed a triple bypass and they sent him down to Weston. Well, why might that be?
Yeah, great question. For those of you that didn't hear the question, we have what is a outstanding heart center here. What would be a reason to be transferred to another heart center? We don't do heart transplant, and there are certain patients that require, without getting too technical, special pumps to be implanted for them to have an open heart surgery. It's a small percentage, but there's still some. And in that patient population, they're better served in transplant centers because of the fact that there's a possibility that something could go wrong. And so there's a small percentage of patients that are transferred for reasons like that, where they require a higher level of care that can only be offered in a transplant center. Next question.
Let me come around. tennis shoes.
Thank you. I must say, the picture you paint is a very different picture than what I had of Cleveland Clinic before I walked in here. And I think it would be very interesting if you took a poll of how many people in this room feel the same, number one. Number two, we all are watching what is happening with our current administration. And I feel very concerned about what can happen to some of the statistics that you're improving upon, given the actions that have been and continue to be taken. Keep up the good work. You're obviously on a good path. Thank you.
Yeah, thank you. I'd add that there's a lot of uncertainty. As we look out and plan for what could be significant increases in our operating expenses related to the supplies that we use, whether it's pharmaceuticals, the implants that we put in, the fluids that we hang, there is a potential impact, and that impact could be anywhere from $5 million to $20 million annually. It's hard to know what that impact will be at this time. Our teams are working on contingency plans to ensure that we can continue to deliver care. Similar to the pandemic, as we think about this, every organization has strengths and weaknesses, every organization. The greatest strength of the Cleveland Clinic is a focus on patients. Because of that focus on patients, they've been able to support growth that most hospital systems couldn't support during these economic times. That also benefits us. It benefits us because if tomorrow we found out that our costs are rising, we have an entire enterprise behind us, ensuring that we can continue to sustain services and care period and need driven. And that is tremendous value, tremendous value. Thanks, thank you for the comment.
Let's take a poll. Can we take a poll? And the poll is? How many here have a different view of the Cleveland Clinic services now compared to before we arrived this evening?
All right, so in case you didn't hear Barbara, has your opinion changed based upon the comments that you heard Dr. Rothman make? So, is that how you would like, so in other words, raise your hand if you now have a more positive impression than what you had when you came in at 5:30.
More positive. Raise the hand.
More positive, so. You have a question, or you have more positive or both?
No, I have one question.
You're welcome.
Hi, I was wondering how Cleveland Clinic kind of evaluates partnerships with like value-based care organizations, or also urgent care to try to help with the flow in the emergency room department, as well as reducing some of those costs that you're currently seeing.
Yeah, great question. All of the above. We have our own organic urgent cares, and we also partner with physicians in the community and all the communities that we serve to come up with more innovative ways to keep patients out of the brick and mortar hospital and triage patients who don't require emergency care to lower acuity settings. In some cases, that is the primary care office, and we've been working with a number of primary care offices across the Treasure Coast to think about how we create a network to be able to decant some of these patients from the emergency department. There's a lot of work to be done there, a tremendous amount of work to be done. Many of our colleagues, both in primary care, these different value-based arrangements, are dealing with the same stresses that we are, and they don't have the access. And so, while altruistic to say, well, we'll get this patient to this location, when they get to that location, they're just as backed up as we are at times. Education of patients is important. Preventative medicine, we believe over time, has the ability to decant the emergency departments and allow people to live healthier lives. And so focusing on both primary prevention and secondary prevention, partnering with the community physicians, organically growing urgent cares are all parts of our strategy. And then reducing readmissions for patients that come in, right? We said about 12.5%, 13% of patients that we admit come back within 30 days. A relatively low number relative to what we see across the country. But all of those components are in our armamentarium to try to reduce the burden of patients coming into the emergency department.
Thank you.
So a couple of the reasons that many of us had a more negative impression, less positive, okay, that I know about are one, the telephone system, it continues to be very, very difficult. And two, that so many doctors left and actually went into concierge practices, which is a whole other issue. But those two are very widespread negative thoughts.
Yeah, and
Thank you.
I'll comment on the phones. We do about 90,000 calls a month. The technologies that enable us to triage phones and that automation is in the process of being integrated into our hospital here. I wish I can tell you it's gonna get better overnight. We're probably about another 12 months out before the phone systems catch up with where we need to be. The demand has far outpaced what we're able to service quickly. Again, we're not the only industry that has dealt with this, right? Many of you remember calling the cable companies, at least I do. I try to forget it. What it was like to call the cable companies in the early 2000s. Your cable was out, and you had to ask yourself, "Do I really want to make this call?" Healthcare shouldn't feel like that. And there's an opportunity for us to automate, to digitize scheduling. We're doing that through our MyChart platform. Those technologies are being augmented and will continue to be augmented over the next 6 to 12 months. On the physician side, it's a challenge. Across the country, physicians are leaving the workforce or going into concierge medicine for a variety of reasons. The concierge patients panels tend to be much smaller. A primary care physician today may see anywhere from have a patient panel of 2,000 to 3,000. Concierge, about 500. Sometimes even less. And so we're seeing attrition into concierge medicine. We're seeing attrition out of the workforce altogether. In this community, I recently saw data looking at the demographics of the physician workforce here in Indian River County, actually across the Treasure Coast. Suffice to say that we will see more attrition as physicians retire because we have an aging workforce. Our ability to bring in physicians depends on our ability to attract young people to Indian River County. And so finding that balance is going to be very important. The physicians that we are recruiting are looking for great places to live that are affordable, where they have things to do, and they can raise a family. We have the school system, we have the best technology. There's opportunities for us to find places or to help develop a community that would harbor some of the younger physician workforce. And not just physicians, physician assistants, nurse practitioners, CRNAs for anesthesia, surgical techs, nurses, registration folks, clerks. Today, almost 40% of our workforce doesn't even live in this county. And so, for us to continue to grow, we really need to think about, and I'm not gonna get into the weeds on this, but we need to think about how we develop across Indian River County infrastructure to support what is a growing demand for services. If we have the best phones, but we can't bring in doctors or nurses or surgical techs, we'll be challenged in access in other ways.
You know, maybe you can be an advocate to improve or increase workforce housing here in the community, because that's been a topic of Let's Talk Bureau in the past.
Sure.
And we've learned that people, I think, intellectually understand there's a need, just as you articulated, but there is not the interest necessarily to expand current infrastructure, whether it's downtown or outside of the city limits. So on your list of things to do, because obviously you need a lot more humans to come in to make all this work.
We do, and I know Kelly and her team have been dedicated to both workforce housing, and it means different things to different folks. All of the above is true. We need places for individuals at various economic brackets, income brackets, to live. And that's physicians all the way down to individuals who are doing non-clinical facing work, but are equally important. We need finance teams and accountants. In order for us to continue to grow our workforce, we're gonna have to create an infrastructure for that. Housing probably is not enough.
What would you say is your biggest concern? I mean, you made a
So-
beautiful presentation, you have got great numbers, but in order for all this to work, like you just said, you need to expand. So knowing what you know today about our little county, what concerns you the most to not see the story succeed?
Yeah, I'm optimistic about healthcare in River County. And look, every county, every state has gone through the back and forth about development, not don't develop. We have a beach here that we're protecting. Some counties have lakes. Some other counties have fields and farms. And I think there's always a debate. There's not a right or wrong answer. The question is, how do we develop infrastructure to support a growing community? And the answer probably is different, and depending on who you ask, and much smarter folks than me probably figure that out. But what I would say is that as we think about the workforce, and if we pulled up the picture of what the workforce looked like, and think about that age and that demographic, what kind of infrastructure would be necessary to support that? And look, everyone in this room probably knows the answer to what that would look like. Where you do it and how you do it, different question. But I think there's a need for the community's value to continue to grow, and I think it will. Having a good hospital really matters. Especially as we think about the community, the average age of the community, there's a need to have the best possible hospital we can have in Indian River County. And thinking about what infrastructure do we need to have, and what compromises do we need to make to support that? And then I'm biased to answer that question.
I just want to say a compliment to you. I think you did, and I know you, and many people will know I know you. You did an excellent job, and as much as I know you, spelling out exactly what is going on with the hospital. Because I think that is a positive for many people in this room that may have come here with a different view. So I commend you on putting the time in, and I was getting tired listening to it, but it was excellent, excellent job.
Thank you.
I was just curious, I know we have primarily an aging population, but what about, adolescents and, pediatrics? Do we take care of any of that?
Yeah, we
Like,
do.
are we
So-
have the capabilities
so
of
the
surgery or ER?
The question is pediatrics. So I'll age pediatrics from birth all the way to the age of, call it 17. So we are focused on the babies and delivering the babies. We partner with Nemours for pediatric care in our hospital. They are outstanding. Their focus is on kids, and they allow us to have a complement in delivering pediatric care. We do pediatric surgeries at the hospital. For more complex care, the pediatrics is delivered at the Nemours Hospital.
Yeah, my question is about your charitable care. I don't know how to ask this, but wasn't Obamacare supposed to help with that? And then the fight against Obamacare, did that undermine people joining up and helping? What's your impact of
Yeah,
Obamacare?
what I'd say is that, well, two facts. When we look at charity care, we know our cost of care went up, right? So 12.5% on supplies and pharmaceuticals, about 35% of our cost, and then on the labor side, our costs are up 40% since 2013. On the wage side, which is about 60% of our cost. So for all the patients that we took care of 10 years ago, that cost has increased. So you have an exponential increase in the cost for any individual patient. And then you combine that with Medicaid is driven by the state. And so at the state level, the state's making decisions about where funds are allocated and how do we care for this patient population. And that's where we're seeing the greatest impact. So our charitable costs went up exponentially after COVID. And the reason for that is during COVID, Florida effectively functioned as a Medicaid expansion state. And so the eligibility for Medicaid was much greater then. Once the pandemic was over, we further restricted, and then we saw a spike in our charitable care, And so that's kind of when we're looking out and saying, what do we believe things are gonna look like over the next year or two? It's based on the fact that we don't have good visibility into that patient population. Coming up with ways to insure all folks is probably a good thing. How you do that, how you fund that, is a question for people, again, much smarter than me. We're in the business of, we can't say no, right? And so we're in the business of thinking about how do we say yes and do it in a way that's sustainable and doesn't compromise our ability to deliver care to the majority of patients.
I know you had a question. I saw you raise your hand.
I can actually talk loud.
So there are two unique things at Cleveland Clinic, Indian River, that you haven't really spent a lot of time on. One, because you're instrumental in starting it, which is home care. And the other thing is, since many of us are either gonna die of heart attacks or strokes, is our unique position in stroke care and what we've done to build that. They're both unique to this hospital.
Yeah, very unique, and I'll comment, we talked a little bit about the heart, I'll comment on stroke. So 10 years ago, if you had a stroke, we used to use clot busting medication to try to reverse a stroke. So I'll give you a scenario. 6, 7 o'clock in the morning, you come into our hospital because you suddenly can't talk and half your body is paralyzed. Common scenario that we see. Many years ago, what would have happened is the physicians would evaluate you, you'd get a CAT scan of your brain, and there's 2 types of strokes. One is a bleed in the brain, and the other is a clogging of the arteries. For those patients that are bleeding, thank you so much. We wouldn't give the clot busting medication. However, for the subset of patients that are having what's called an ischemic stroke, which is the majority of strokes, we would give a medication to try to bust up the clot. That was 10 years ago. Fast forward to today, there are special procedures that allow us to go into the brain with a small catheter, navigate the catheter to the clot using what's called biplane imaging, and pull that clot out. The only place to get that done is the Cleveland Clinic here in Indian River County. Why that's important is that same patient that used to come to our hospital, half paralyzed, and by the way, leave the hospital maybe just a little bit better. Within 24 hours after the procedure, they're walking again. And it's tremendous. Now, we're victims of our own success, because you can guess what happens if somebody picks a patient up in Sebastian. The first thing they say is, if they're having a stroke, take me to Cleveland Clinic. If somebody needs charity care, the first thing they say is, take me to Cleveland Clinic. You have a heart attack, take me to Cleveland Clinic. And so what's happened is, this goes back to the phones, the emergency departments. There's an insatiable demand for these services. It's not because we're the only ones offering these services, because there's no one that offers them better, because there's no one that's more focused on the patient. But the stroke care is one where it's been transformative, and the procedure is called a thrombectomy. So we're a primary thrombectomy center. Again, we go in, we have a special CAT scan. The CAT scan also does something that's really cool. So it used to be about a year ago, about 5-8 years ago, if you woke up, by the way, unlike a heart attack, most heart attacks happen between 3 to 6 o'clock in the morning. Your adrenaline starts to surge. You have chest pain, you wake up and you call 911. When you're having a stroke, there's no pain. So what happens is you wake up and you suddenly can't get out of bed and you can't speak. If that happens and you don't have access to a thrombectomy center, we don't give you blood clotting medication, because we don't know how long it's been since you were last well. We can only give it within 4 hours. So if you wake up with a stroke and you're not near a thrombectomy center, it's conservative treatment. However, we have a special CT scanner today at the Cleveland Clinic that if you come in with a stroke and you've woken up from the stroke, we can scan your brain. The CT scan can tell us, based on the penumbra or the area of the brain that's suffering from the stroke, if we can reverse it. So now, what's called a wake-up stroke, we can actually go and pull the clot out. And in many patients, they're walking out of the hospital. That technology, get probably more detail than many of you are interested in. That technology is all available at the Cleveland Clinic. And I tell you this more, not to highlight that, we're really focused on trying to deliver care that the community needs but also to talk about why it's so busy there. Many people don't see this. Our hospital gets more emergency department runs than any other hospital in the Cleveland Clinic, from everywhere. And so look, we're lucky that we have this hospital here. And we're lucky, I'm lucky that all of you hold us to a high standard, right? The expectation is good care. The expectation is access to that care. We're invested in figuring out how to do that in a way that's sustainable in what's a somewhat of uncertain economic environment.
I have a little story and one question.
Sure.
I have a positive story that I wanted to share as well. That my father had was actually visiting here from the Netherlands, and he had an acute aortic aneurysm. And I must say, Cleveland Clinic was incredible in his care, bedside manners, and they actually saved his life. And I was after surgery out in a few days and recovered really well. So it's not all negative. There are a lot of positive stories that, of course, a lot of people don't share. So I want to give that story up. The question I have is for the providers that you have. Do you have like daycare for them? Like I know in a lot of hospitals where I used to go around, I did not live in Vero, they had a lot of daycare for their doctors and their other providers.
Yeah, we don't currently have a daycare located on the campus. We have been working with some of the community daycares to help set up places for many of our younger folks who have young children, but we don't have a daycare. It's certainly something for us to continue to think about exploring. I know I get this question from many of our employees. It would be a boon for a lot of folks that work at the Cleveland Clinic and New River Hospital to have that kind of an infrastructure. So I think it's something that we should continue to try to look at. In the interim, what we've done is we've partnered with some of the local preschools to allow early access. You'd be surprised. Preschools are really competitive today, but they're really competitive and expensive. And so the point is though is that we've partnered with a lot of these preschools to try to get our nurses, our doctors, kids into preschools that are near the hospital. Thanks for the question and for the story. For those of you that are not aware, in aortic dissection, the aorta takes blood from the heart, and it's the vessel that has the most pressure placed on it. And so when the heart pumps, it pumps blood into the aorta that then distributes out to the rest of your body. That pressure can cause the aorta to tear or to grow. And when that happens, you need open heart surgery. And so our cardiothoracic team does a fair number of aortic repairs right here at Vero Beach. And it's something that we don't talk a lot about, but they do an outstanding job. And thank you for the story.
So we have time for one more question, and then I need to share a couple of thank yous with you. So Barbara has a question, but I'd like to see if anybody else has one, because Barbara was already nice enough to ask a question. Okay.
You're gonna go for it.
Go for it.
So in most hospitals, there's a rather substantial nationality distribution. And I think it's fair to assume that this distribution is going to be rather encumbered in the future. And I wonder if you and your colleagues are making an effort to promote students going into the medical profession in the high schools, lower schools,
Yeah, so
in Indian River County, for example.
Yeah, so we have partnerships with both the local schools and the Indian River State College. If you were to come, and if anyone's interested, waking up at 6 in the morning. So if you come to the hospital at 6:30 in the morning and you stand in front of our employee entrance, you'll see about 35, 50 nursing students, respiratory therapy students, surgery techs, all lined up waiting to go in. It's actually fun to watch, and it's rejuvenating to see, unless you don't like to be up at 6:30 in the morning. But yes, so we're continuing to look at ways, but that's important too, because what it does is it allows us to say, we have good schools here. We have good schools, and longitudinally from elementary school all the way through to the colleges, we now can give you opportunities to work in healthcare that for many kids, they would have to go away for. And we can now provide that opportunity right here in Indian River County.
don't leave, because I want them all to give you a big round of applause, but you know, when you do public speaking, you know how you always forget something? So let me catch up what I should have mentioned to you at the beginning, because obviously we owe a huge thank you to the theater that they kind of squeezed us in, because they're going to have a swarm of humans come in for the 7:30 show. So, but I promised Lori that I would share with you who the shows will be next year. So, Little Shop of Horrors, A Gentleman's Guide to Love and Murder, sounds interesting. Jesus Christ Superstar, 9 to 5, that's an old goldie. All right. How do you pronounce? Mauritius, thank you. And you told me how to pronounce it, and I forgot. And Almost Maine. So that's for the theater. Thank you, Lori, and all of your staff. And then on the handout we put on your chairs, we would like to thank Kimmy Coveney, Austin Dingwell, Christine Hughes, Morgan Reynolds, and Ed Shanahan, who also helped put this program together for you this evening. So again, we owe you a big thanks. I know time is most elusive and it's your most precious commodity. So you shared almost 2 hours of your most precious commodity with us, and we are very grateful, and we hope you can do it again. Okay.